of our first forum with a session on HRT. So over to you, Hala.
Hello and good afternoon to you all. So my name is Hala Danoon. I'm a clinical pharmacist in Southwest London, Morden Hall Medical Centre. I'm more of a GP-based practice like Sonia, so started as a PCN and then moved on as a practice-based. Before that, I had experience of being part of the Women and Children team at King's College Hospital for 10 years, and prior to that, I did community pharmacy. So again, a wide variety of different roles, which is really interesting, and I think most of us are enjoying the primary care roles and the GP practice. It comes with its own challenges, but they are, I think, interesting challenges. Today's presentation is going to be HRT. Another role that I do is that Sonia and Kay. I lead the Southwest London GP, PCN Pharmacists Forum. We started a year and a half ago, same numbers about 25 to 35, and the last session we had about 100 attendees. So it's growing, and it's really having a positive impact on the progression of pharmacists in the area, support, networking, having clinical supervision. So I'm sure this forum will also grow just as well as we did. Okay, so I'll share my slides now. Let's get rid of this one. Can you see the slides?
Yeah.
Yeah? Okay, I'll just move. So the main thing is about talking about HRT, the different formulations, the common side effects, addressing switching with the current climate of having out of stock on daily basis, knowing what's available and how to change. When I do my HRT, I like my attendees to understand what are we looking at, what are we trying to fix. So if you look at the presentation, you will see that the estrogen itself has, when we reach the menstrual cycle, it goes up and have a small dip and then goes up and down again. And the progestogen, which is the navy curve, it goes up towards the end of the cycle, and then that's when we have the menopause. In menopause and perimenopause, the quality of the eggs start to reduce, which means the production of estrogen starts to become less. So it's not going to be a steady line where it's continuously at a low. It goes up and down. So if you can look at that curvy graph, it shows that the estrogen goes up and down, but it's significantly lower than the estrogen, the green line. And that's where the symptoms start to appear, and that's where the women start to have the perimenopause and postmenopausal symptoms. So what are the benefits, the main benefits of HRT? And the name itself, it tells you hormone replacement therapy. So you're literally trying to increase that level of estrogen back to that beginning of the green line. So if I go back, so we're literally trying to bring estrogen level somewhere around here, just to provide that relief of those symptoms. We're not trying to use it there, we're literally just trying to bring it up from a lower level to a higher level. So what are the benefits of HRT? The main symptoms of menopause will be the vasomotor symptoms, which is hot flushes, night sweats, brain fogs, joint pains. So the HRT will help control these symptoms. It will also help with the vaginal dryness that is due to the low estrogen level, and that by itself will improve sexual function and also reduce the UTI symptoms. It improves sleep because they're not having the night sweats, the joint pain, and the quality of life. It has also a positive impact on bone mineral density and reduced fracture risk, because as your estrogen reduces, the position of calcium and phosphate on the bones reduces. So there's increased risk of fracture. So with the HRT, we lower that risk. It can also improve psychological symptoms like depression and anxiety, especially when they are related to the low estrogen levels. If the HRT started at an age less than 65, they're looking if it has a beneficial or versus no changes to cardiovascular disease. At the moment, we know that there's no increased cardiovascular disease if started under 65. But I think there are clinical trials where they are looking at if actually it gives cardiovascular protection. Also, we're going to look at premature ovarian insufficiency, which is going to come next. What are the risks of HRT? So there are different risks that comes with any medication or anything that you consume. And what I normally tell my patients is everything you consume has a good effect and has a side effect. Even water, you drink a lot of water, you'll be well hydrated, great skin, but at the same time you'll go to the loo to pass the urine. So again, with HRT, as we saw, it has great benefits, but it comes with its own risks. The first one is the venous thromboembolism and the risk of having a DVT or PE. Now, oral HRT comes with that increased risk. However, the transdermal route, whether that's a gel or patch, does not come at a greater risk than placebo. With breast cancer, again, we look at the baseline of breast cancer of women around menopause age and compared with HRT. Okay, lifestyle as itself, like smoking, obesity, excess alcohol, have a much higher risk of developing cancer and causing cancer than the HRT. Nevertheless, we still need to advise patients to be aware of that risk as per the MHRA 2019 alert. Always advise them to examine themselves regularly, their breast, any changes that they need to report. HRT with estrogen alone is associated with little or no change in that breast cancer risk. So the ones that have a progestogen with it has higher risk than the estrogen by itself. But that doesn't mean that we can only give the estrogen, and we'll come back to that in a minute. Vaginal estrogen, the topical one, whether it's a pessary or a cream per vaginal, does not increase the risk of breast cancer because it has a very low systemic absorption. It is used for that local estrogen buildup. Combine HRT with the estrogen progestogen associated with increased risk of breast cancer that is duration dependent. However, some studies shows that even after stopping the HRT for 10 years, that risk might still be there. The micronized progestogen and the dydrogestogen may be the safest progestogen. The micronized one is the closest one to the body bioidentical kind of like progestogen. Risk of cardiovascular diseases and stroke. Now, cardiovascular disease is the commonest cause of death in postmenopausal women. And as I said earlier, for women who start HRT at an age less than 65, there is no increased risk of cardiovascular disease. It can actually be more cardioprotective for the started at less than 10 years from the last menstrual period. So again, as I said, there are still some clinical studies to prove that. Stroke is increased when oral, but not transdermal HRT started in older women, which is more than 6 years old. And that is due to the risk of thromboembolism. Tibolone is a oral HRT. It's an old kind of like generation of HRT. Increases risk of stroke by approximately 2.2 times from the first year of treatment as per MHRA guidance. So probably maybe if you practiced 10 years ago, you would have seen tibolone widely prescribed, but not anymore. Ovarian cancer, slightly increased risk has been suggested from epidemiological studies, although causation cannot be inferred. Endometrial cancer, now this is the important one. The reason why it's important is, if you saw the first slide where the progestogen comes higher towards the end of the cycle, and then it goes down for the menses. Progestogen, when a woman has a uterus or any endometrium, is important because it protects that endometrium from hyperproliferation, so it prevents that cells within the uterus to change into cancerous cells. And that's why it's important when you do your medication review that you make sure that the patient is coded if she has had a hysterectomy, subtotal hysterectomy. Is she been using both hormones, progesterone and estrogen? Is she on one? So it should be well documented and coded. So when we do a counseling for HRT, what are the things that we need to look at? So we need to do a full medical history, including personal, family, medication history. You need to have your weight, height, BMI checked, the blood pressure, all of these things. As you do with the combined contraception or the normal contraception, you need to have these baselines checked. Also check for the psychological symptoms such as mood disturbance, anxiety, depression, and consider referring to CBT therapy as per NICE guidelines, because your hormone replacement therapy will have a space to help with these symptoms, but the patient might need further support. NICE also advises that SSRIs and non-SSRIs or clonidine should not be routinely used as first line due to limited efficacy. So we normally say these to patients who have contraindication to HRT. So they should not be used as first line. Vaginal estrogen products should be offered to patients with genitourinary syndrome of menopause, which includes, even if they have a systemic HRT, but they still have complaining of multiple UTIs, dryness, itchiness, then we can prescribe them vaginal estrogen in addition to the systemic HRT. So the choice of HRT in women post-hysterectomy. Okay, so there's 3 different types of hysterectomy. The first one is subtotal hysterectomy. So the uterus is removed, but there is still some residual endometrial tissue. As I mentioned, as long as there is endometrial tissue, we need to have the progestogen there. Okay, so we need to consider first to use the sequential, okay, and check, is that woman going to have a bleed? We need to trial it for at least 3 months. If the woman bleeds, that means there is still remnant endometrial tissue, and that means when we move to the continuous, you have to have the progestogen there. If the woman does not bleed within that 3 months trial, then most probably there is insignificant amount of endometrial tissue. So you can move her to the estrogen only and then continue with that. We still do a review about bleeding every 6 months to 1 year to check if there is any bleed. If the woman had a total hysterectomy where the uterus and the cervix were completely removed, then you don't need that progestogen anymore. You only need the estrogen in HRT. If a woman had a total hysterectomy with both of her ovaries removed, we need to look at the reason. If it was done because of severe endometriosis, then we need to continue with having both the progestogen and the estrogen to avoid any further risk for the future. If there was no history of severe endometriosis, then you can continue with the estrogen only HRT. I hope that's a bit clear. You will have the slides and hopefully you can refer to them when you need. Now, if we have a woman with an intact uterus, so the uterus is still there and we still need to use the progestogen and estrogen, we can subdivide those into different categories. The first one is women with premature ovarian insufficiency. So what that means is the woman producing an egg and the egg is not producing enough estrogen. And normally these are women at a younger age, in their 20s, 30s, or early 40s. The HRT that we will recommend for them would be a sequential HRT because they're not postmenopausal. They have those symptoms due to the quality of the egg. So they can go on the sequential combined HRT or a combined HRT or a Mirena plus estrogen. So anything that has both estrogen and progestogen, because the uterus is there, it's just there's that drop in the estrogen level that we need to bring up. For women in the perimenopausal period, which is identified as the period of 1 year after the last period. Again, they can go on the sequential HRT, or if they already have a Mirena coil, then we just give them the estrogen, and the Mirena will provide the progesterone for the HRT. Women in the postmenopausal period, which is more than 12 months since the last bleed, we offer them continuous combined HRT. Women with an intact uterus with Mirena coil in place, the Mirena is already providing the progesterone side of the HRT, so you only need to offer the estrogen. Women who have undergone endometrial ablation, then they need the combined HRT regime, whether that's sequential or continuous, and should be used in women who have undergone endometrial ablation to ensure the entire residual endometrium is protected and reduce risk of endometrial hyperplasia. So what other adjunctive progesterone and HRT can we do? So as I said, the Mirena coil has the progesterone on it, so that can work as the progesterone side of your HRT. Medroxyprogesterone is another, which is Provera, which is available, I think, nowadays. Now, if you look at the dose of the cyclic and the continuous, the cyclic is where we need it to go up and then down, and the dose is higher, and you need to give it 12 days. So you give them the 10 milligram for 12 days, which is days 15 to 26. So if you remember the first slide with the graph going up, we need that progesterone to hit that high and then go down. And then that is your cyclic. If you're giving it the continuous, where you have a woman established postmenopausal, you don't need to go up and down. You just need to have a steady amount of progesterone to go with the estrogen. And that's where your dose is between 2.5 to 5 milligrams. And that's every day of the cycle. The other type of progesterone is the etradiol, which is a mechanized progesterone. Now, this is the highly favorable one, and as I said, because it's the bioidentical progesterone, and most of the private clinics are recommending this one, so you will find a lot of women trying to get this one, and I think it's still out of stock in some of the pharmacies. Again, with the cyclic regime, if you can see, it's a 200 milligram orally at bedtime for 12 days. So you go through that peak, and then it comes down, and then that will trigger a bleed. The continuous in the postmenopausal, you will need a lower dose of 100 milligram once a day, every day. If we look at the different estrogens comparative doses, so we have the oral, the patch, the gel, and the sachet. This is a table to help you convert from one formulation to another, depending on what's available in your local pharmacies or out of stock. Why do we like the transdermal HRT? So we normally recommend it for patients who have poor symptom control with the oral treatment. So you've tried it for 3 months, they chose the oral, you've tried it for 3 months, and they're still symptomatic. You can try then to change them to a transdermal formulation. If they have a history or a risk of venous thromboembolism, you need to refer such patients to a specialist in order to assess the risk and choose the most appropriate regime. So, for example, if you had a patient who, at some point in her life, she was pregnant, she had a DVT, and now she's postmenopausal and she wants to have HRT. Although that we said the transdermal route is safe and does not increase the risk of DVT and PE, it is always a good idea to refer back to a specialist to be assessed for the risk and then for them to prescribe or initiate HRT. If a patient has a variable hypertension, it should be controlled before starting HRT, because we know hormones in general can have a increase on the blood pressure, just like when you do with the contraceptive pills. If a patient is having side effects to the oral preparation, or they're having nausea or not tolerating it, then you can change it to transdermal. If there are conditions of the liver, because we know oral gets metabolized by the liver, so we try to avoid that route if we know that there is a hepatic enzyme inducing agent. if there is gallstones, then these are kind of like conditions where we try to avoid the oral side and go for the transdermal. If a patient has hypertriglyceridemia, again, we go for the transdermal. If they have bowel disorders where you think that the absorption is going to be affected, then the transdermal route will be more reliable. History of migraine. The reason why we suggest going for transdermal is because you are having a more steadier hormone levels coming out of the transdermal route than from the oral. So you're not having the elements of the food, timing. So all of this will reduce the risk, the possibility of having migraines. Now we come to the bleeding concerns with HRT. Now, when you do the review, especially when you initiate a woman on HRT, you need to understand the bleeding pattern. And the way I normally explain this is normally progestogen is the one responsible for the bleeding. If you start a woman on HRT and she's bleeding, then most probably her progestogen levels are not high enough. However, high doses of estrogen can also cause a bleed. As a woman grows older, her need for estrogen decreases. So we should always assess and give the minimum effective dose. So when you do your review, check the dose of the estrogen. Is she on 100 microgram of the Avril? Is she on 4 pumps of the gel? How long has she been on it? What's her age? What are her symptoms? We'll come to see the different side effects from each of the hormones, and that will give you an idea to see which hormone is causing these side effects. So if a woman is on the cyclic or sequential HRT, and she is the bleeding, we expect it to be heavier at the beginning, but it starts to settle down after 2 to 3 months. And it's normally generally same as the patient's natural periods. 5 to 10% of women do not bleed on cyclic HRT, and that's due to atrophic endometrium. With a continuous HRT, now we expect them to have unpredictable irregular bleeding for the first 3 to 6 months, okay? But then should settle down. If heavy or continuing that bleeding goes on after the 6 months, then you need to consider investigation and send for an ultrasound. If the woman has been using HRT and she was fine for a year and then suddenly she develops a bleed, then again you need to send for further investigation. Bleeding patterns generally are better with low estrogen doses as the woman gets older, as I mentioned before. Now, how do we deal with those bleeding problems? If a woman is on a cyclic or sequential HRT and she is complaining of bleeding issues, so first thing is consider compliance. Is it an oral medication? Is she taking it as prescribed? Are there any drug interactions? Any other problems? So get another medical history for the patient. If the woman have heavy and prolonged bleeding, then increase or change the type of progestogen or reduce estrogen dose. So if the estrogen, let's say, was at 25 or 50 microgram, this is already a low dose. So then you look at the progestogen. What dose of progestogen is she on? And I think it's important to understand bodies are not textbooks, so everybody's different and everybody's going to react differently to medication. So what is suitable for one person might not be suitable for another. So as long as you kind of like trial with the progestogen, increase the progestogen, reduce estrogen where possible, and then give it a few months, 2 to 3 months, and then assess again. If it's not working, then you can refer to the menopause clinic. If a person is bleeding early in the progestogen phase, increase dose of progestogen or change type. If the bleeding is painful, then it could be the type of the progestogen. Okay, so you might want to change it to an androgenic progestogen. there's a slide about the different types of progestogen. If a patient is having irregular bleeding, then change the regime or increase progestogen. So as you can see, it's either increasing progestogen or lowering estrogen. So these are kind of like your bleeding control elements. If a woman is on continuous HRT, bleeding patterns are better with a lower estrogen dose. Make sure that the patient is compliant with the prescribed HRT. In trial to increase the progestogen dose, because with the continuous, your estrogen is normally fixed, and your progestogen if you come for the ever continuous, for example. So you might want to top up the progestogen side with a extra 2.5 Provera, for example. Some women will bleed despite atrophic endometrium normal uterine pathology. So if you do the investigation, everything is fine, you're controlling the symptoms of the menopause, then you can continue with the HRT as long as you eliminated any underlying pathological reason. So if there's a lack of efficacy, what do we need to do? So we need to consider the following causes. The magic number in the world of hormones is 3 months. So I always tell my patients, give yourself 3 months for your body to settle with the new hormones. Okay, so don't come back too soon to think this is not effective. Maybe the estrogen level is not high enough. So normally the starting point of estrogen is 50 microgram transdermal patch or 1 milligram oral. If she's getting some relief but not complete relief, then consider increasing that estrogen to a higher level. Check with the patient's compliance. Are they taking their medication regularly as prescribed? Do they have absorption or metabolism issues? Do they have any concerns about taking the HRT? And also always consider if the symptoms are not menopausal, especially when it comes to anxiety, brain fog, joint pain. Keep your mind open for other causes that could be non-menopausal. So normally HRT takes about 3 months, between 1 to 3 months for the vasomotor symptoms. The urogenital could take between 3 to 6 months. Psychological symptoms are variable response because we don't know, is it menopausal symptoms or are there any underlying causes for that psychological symptom. Now looking at the side effects profile for both the estrogen and progestogen, I think it helps when you do a medication review to understand what is causing what. So mainly with estrogen is the breast tenderness and enlargement, leg cramps, bloatiness, nausea and headaches. These come normally with the estrogen. If the woman is starting the HRT, then give her about 3 months to settle. Normally the body will get adjusted. After the 3 months, if she's still having those side effects, then reduce the dose or change the route. If there's good control of the menopause symptoms, but still the breasts are kind of like tender, then they can use evening primrose oil or safflower oil. If they're having GI symptoms, then take it with food or change the route. Other side effects can change the type of route of the HRT again. The progestogenic side effects, so they are kind of like similar to the menstrual cycle symptoms, which is again breast tenderness. It's more lower back abdominal pain, backache, depressed mood, acne, greasy skin, and headaches. So you can look at changing the progestogen type. The testosterone, or what we call the androgenic progestogen, are northestrone, nogestrel, and levonorgestrel. The ones that are derived from progesterone are the medroxyprogesterone, dydrogesterone, and drospirenone. You can always change the route, and sometimes I tell them to have a steady input of progestogen is through the Mirena coil. So that helps you make sure that you have the steady level of progestogen will help against these side effects. will not get affected by oral absorption. If the patient is postmenopausal, you established after 1 year of being on the cyclic regime, you can move them to the continuous, because the progestogen, as I said, level will be half of the cyclic. So you're jumping from 10 to 5 or from 200 to 100. So that by itself can help control the progestogenic side effects. So contraception, intrauterine and HRT. So if you remember the first slide, and when I told you that we're trying to bring the estrogen levels back to the minimum estrogen levels in a normal cycle. So that means we're just trying to bring it up to that level to control the spasmomotor symptoms. So you're really nowhere near the contraceptive effect of a combined oral contraception pill, because the levels needed in the combined oral contraception is higher than from HRT. HRT is not a contraceptive measure. It will not prevent spontaneous ovulation in perimenopausal women. If a woman is over the age of 50, then you need to advise them to have contraception for at least 1 year after the last spontaneous period. If a woman is under 50, then she needs to have 2 years following the last spontaneous period. If the patient is fit, healthy, non-smoking, non-retentive, then they can continue with combined oral until the age of 50, and then you change it to the progestogen only as per UK Med recommendation. Barrier method becomes safer in older women as fertility declines and have lower failure rate. Mirena is a great, as we said, because it ticks so many boxes. It gives you progestogen, gives you contraception, it's a steady levels of progestogen. So if you have women who are on it, it's much easier for everybody. However, the intrauterine device is licensed for 5 years in HRT use. When do we refer to a specialist? So, as I said, some women have premature ovarian insufficiency, and normally they are the younger women under 40. We need to refer them to the menopause clinic, because we're not only looking at menopause symptoms, but we're looking at fertility and if they want to have children. If a patient has a complex medical history, where, as I said, they had a history of a thromboembolism at some point in their life, or other factors where essential hypertension that's not controlled, you might want to refer them to a specialist. Safety concerns of HRT, and that I think comes with patients who had breast cancer. So it's contraindicated for patients who definitely had a hormone-positive breast cancer. Persistent treatment problems like side effects or lack of efficacy, bleeding problems despite trying the different methods that I just mentioned, or if the patient requests to see a menopause specialist, you can refer them to a menopausal specialist clinic. If there's a history of hormone-dependent cancer, as I said, or if a patient has a BRCA gene positive, so they have the gene, even though they did not have the cancer, but they carry the gene. If they have a bleeding symptom, then during sequential therapy, as we said, if there's a change in the pattern of bleeding, where the duration of the bleeding is getting longer, the frequency is getting more, and it's getting heavier, and they are already sequential, and this is continuing, they're referred to a specialist for further assessment. If they are on the continuous, where you have both progestogen and estrogen are going on, and they're still bleeding after 6 months of initiating that, then you need to refer. If a patient is on a selective estrogen receptor modulator, any bleeding whilst on the therapy should be treated as postmenopausal bleed and warrant an investigation. So let's say, for example, a patient is on tamoxifen, and for some reason she was started on HRT, despite that means she had breast cancer, and then she develops a bleed. You need to treat that as the same as a woman who's been postmenopausal for more than a year and she had a bleed. Because technically, the selective estrogen receptor modulator should block the receptors for the estrogen, so it should not bind. So if they have a bleed, that means there's a problem. Additional treatment options. So testosterone has been big on the press recently, and normally we reserve it for patients who have experienced loss of libido. In Southwest London, it is Amber 3, so it has to be initiated by a specialist. But then we can take, actually it's an Amber 2, then we can take over the prescribing after that. It cannot be prescribed by primary care. The key group are women who had a hysterectomy and bilateral salpingoophorectomy, who lost about 50% of their circulating testosterone. However, even women going through a natural menopause, uterus and ovaries intact, may in some circumstances benefit from testosterone replacement. There are no licensed treatment available for women. However, it is Amber on Southwest London formulary. There are many issues affecting libido, so if testosterone replacement is being considered, specialist referral is advised. What I would suggest is make sure that the patient is on the correct dose of the HRT, that you address any vaginal dryness as that might cause a problem. If those things don't work, then you refer to the menopause clinic. Tibolone is what we call a gonadomimetic, so it has all three different hormones properties: estrogenic, progestogenic, and androgenic. So we consider it the same as a continuous HRT, but with an added androgenic activity. So technically that should be good for women who have experienced libido on the continuous HRT. However, it does increase risk of stroke in women older than 60 years old. I haven't come across anyone who's on tibolone, to be honest. Also, tibolone can have an effect on anticoagulation such as warfarin, so make sure that the patients get checked for their INR when they start on tibolone. What does NICE give a recommendation? First one is provide evidence-based information about menopause treatment options and help women to make informed individual decisions about menopause management. We do not need to use blood tests when we're trying to diagnose perimenopause or menopause in women aged 45 or over. HRT is the first line for menopause-related vasomotor symptoms and low mood. We do not routinely offer clonidine or antidepressants. Do not use fluoxetine or paroxetine on women taking tamoxifen because it can affect the binding of tamoxifen to the estrogen receptors. So you put a woman at a higher risk of getting breast cancer again. Offer long-term vaginal estrogen for urogenital symptoms, even if taking HRT. Understand appropriate review and when to refer. Support women to choose when to stop HRT. Okay, so every woman is different. Some of them would want to continue, some of them want to try to reduce. So discuss with that woman or that patient and understand what to do. Use Victoria charts to discuss long-term risk and benefits of HRT. They are widely available, I think, on the BMS, British Menopause Society website. Use blood tests to confirm diagnosis of premature ovarian insufficiency and offer hormone treatment up to average age of menopause at least, but that is normally, as I said, for the menopause clinic, not for primary care. These are some of the useful websites. Southwest London quite recently published the menopause guidelines, and to be honest, they were the best guidelines I came across for about 5 years, and I think they were thinking about cascading the same guidelines throughout nationally, not just in Southwest London. I left the link of the second one. If you have any queries, please use it. It's really, really good. So that's the end of my presentation. Any questions?
Thank you, Hannah. We've got one question in the chat box. So Mohammed wants to know, is the first choice oral or non-oral?
Given the risk of thromboembolism, I would normally suggest going for a transdermal rather than oral. I never suggest oral unless the patient specifically wants to have oral. I do say that there's these formulations, but my instinct is to go for a transdermal option rather than an oral.
Thank you. Anybody else got any questions? I can't see any other questions in the chat function. Anybody?
Anybody in the group deals with HRT, menopause?
I've got a question.
Oh.
Yes.
Sorry, this is a question for Kay. Are we going to get any CPD certificates for this, attending this?
That would be a question for Julie, actually. Julie?
I'm not entirely sure. I'll double check it with Zara now and I'll let you know. I'll put it in the chat box, okay?
Brilliant, thank you.
All right.
I've got another question now from Mohammed. So when do you
I've
change?
got another question as well.
Oh, sorry, Faria. Go.
Sorry. This is for Hala. Thank you, Hala, for a very informative and useful webinar. Could you signpost us to any organizations or websites which provide learning support? Because with CQC, they do want to see proof of a CPD, like a certificate.
So the BMS has good wealth of information for the healthcare professional. And if you have a special interest in menopause, they do have the Obs and Gynae with focus on HRT conferences, which carries over 2 days, I think twice or 3 times a year. So that is a really, really good resource because they cover so much more than just HRT. So in today's webinar, I literally just covered hormone replacement therapy. I did not touch on the menopause, didn't touch on other risk factors, did not touch on alternative therapies, risk of fracture. So today was just literally HRT. But if you look at the BMS, they look at different resources and there's lots of reading in there as well. So it's a really, really good resource for the healthcare professionals.
All right,
I think also, Farida, if you do want to have a deeper dive into menopause and HRT, you know, there is opportunity to feed that back into us, and we can certainly look at having something more formal in place if that is what you need as well.
Yeah, okay. All right, thank you.
I've got another question from Mohammed, and he's asking you, Hala, when do you change sequential HRT in perimenopausal women?
So the ground rule is normally 1 year after the last period. However, if you change them after 1 year to a continuous and they're still bleeding, most probably that means they have some activity in the ovaries that are still perimenopausal, but they are longer perimenopausal than the normal. Okay, so you need to assess. So the ground rule is 1 year, and then after that 1 year, you should change to continuous. However, if you change to continuous, they still having regular bleeds, move back to the sequential for another 6 months.
Hopefully that answers the question, Mohammed. I've got another question from Alicia. So if someone has a first-degree relative with breast cancer and requires HRT due to menopausal symptoms, what would you consider HRT?
So I will have a full consultation with them. I will try to understand what type of breast cancer. So breast cancer comes in 4 different types: progestogen, estrogen, protein, and triple negative. So if a woman is the first degree relative are the estrogenic or progestogenic positive breast cancer, then I will discuss with that relative if they've had a BRCA gene tested. If it came back as negative, then her chance of developing breast cancer is the same as any other woman. Now, you need to address their concerns and you need to assess menopause symptoms versus their well-being and their risk and their what they want and quality of life. And then the patient needs to make that decision. I can put in the recommendation, I can discuss the risks, but the decision ultimately comes down to the patient. If the BRCA gene is definitely positive, then I do not start HRT. Then that means because they are at risk of breast cancer, and if they have terrible menopause symptoms, then I will refer to a menopause clinic. If it is not BRCA gene, if it's not a hormonal cancer, then I will discuss with them HRT at a lower dose, especially with the continuous one, because you can control. And then we'll take it from there. But I will always reiterate for every single person that I review, please examine yourself regularly. Make sure that if there's any changes on the breast, whether that is an unexplained itch, discharge, lumps, change in shape, any changes, call us back, and then we will send for a mammogram.
Sorry, can I just ask one more question? I think about the sequential. It's Faizan Muhammad is my first name. You mentioned about sequential in perimenopausal. So from your presentation, I think my understanding is they get bleeding anyway every month if they are perimenopausal symptoms. So do you continue with the sequential until the period stops at the age of 50?
So as I said, so the guideline is to have the sequential for 1 year post the last period. Now, this is a difficulty if the patient is on some sort of a contraception. Because as we said, that HRT is not contraception by itself. If they are under the age of 50, they will need to take 2 years of contraception. So that makes your life a little bit more difficult to assess if the patient is perimenopausal or postmenopausal. So what you can do is you can move them to a continuous and then monitor them for 6 months. If they start to get a bleed, most probably they're still perimenopausal. Now, with the sequential, yes, after a while, they should stop bleeding. But that, again, if they're still bleeding and they're on the sequential, you stop it and you move to the continuous. If the bleeding continues, move back to the sequential. Does that make sense?
Yeah, that makes sense. Yeah, it can be difficult with perimenopausal.
It can, especially when we're not doing blood tests, Mohammed.
Yeah.
You don't know the levels. Even with the levels, to be honest, because the ovaries is not producing quality eggs, and we don't know if that quality is every month or is it every other month. So it's hard to pick up the correct reflection at the right time.
Yeah. And in the in menopausal, obviously 50 plus, then you always start with continuous HRT anyway. Yeah.
So not necessarily. So if they're postmenopausal, they have not had a period and they're over the age of 50, then yes, it's continuous. But I have some woman who's 55 years old. She's still having periods erratically. So I started.
And in terms of duration, I think I've read like, can we consider or giving 5 years or 4 or 5 years time for HRT to be continued after the age of 50? So say, for example, if someone is perimenopausal at the age of 43 and they're on HRT all from last 17 years, then coming to 50, do we change? Do we ask them to continue for another 5 years or ask them to stop, or any guidelines on that?
So the problem, Mohammed, with menopause, the symptoms are related to the low dose of estrogen in the body. However, as we grow older, women need less estrogen. So you might have a woman who was on HRT for 10 years and then she starts to produce to stop, and then suddenly she gets her hot flushes back and she immediately wants to go back on HRT. So it's different from one patient to another, and the severity of the symptoms affect quality of life. So you really need to assess, is that what the patient wants? Have they tried to reduce the dose first? Have they reduced it, they were fine, and you want to reduce it further? So it's not a treatment, it's a replacement.
Yeah, no, that makes sense. Yeah, no, that makes sense. Yeah, no, I've seen women like at the age of 70 and they're still having it. So yeah, that's fine. Thank you.
No problem.
We've got one last question, but I think, Hala, you've actually kind of answered it. So Farida's asked, at what age would you stop HRT? Which I think
there is no age, Farida. honestly, I don't know if anybody has been through menopause, but the symptoms of hot flushes, night sweats, joint pains, brain fog, they're not pleasant. And especially the hot flushes and the night sweats. So nobody wants to go through their life going through symptoms every single day. So there's no age for HRT. You're literally just trying to bring up the level of estrogen to the minimum level where they are symptoms free. And that's why it's called hormonal replacement, and it's not a treatment. We're not treating the ovaries, we're just literally trying to give them enough supplements to reach a level where they are symptom free. But that level drops as we age. So the woman in her 40s, you expect her to be on an estrogen of 100 microgram patch, while somebody in their 70s might be on a 50 microgram. Somebody in their 80 might be on a 25 because they still don't want to stop the HRT. So just be aware that the level of estrogen need in the body drops as we age.
Brilliant, thank you, Hala. I don't think I've got any other questions in the chat. Has anybody else got any other questions for Hala before we let her go? I take that as a no, then. We just want to thank you, Hala, for your really informative session. Certainly I've taken a few points away, and hopefully